Hey guys, it's Sunday. I thought I'd take some time to go over week three's cardio and get going on our last week of cardiovascular disorders. So within this series, this one video of a series of three, we're going to get more into the ECG, and we'll go over some of the rules, the 5 rules that to go by. We'll watch a 10-minute video, and we'll also discuss different stents and tools that they use to treat, some of these syndromes, like acute coronary syndromes, and how they treat these aneurysms and things of that nature that we're going to cover. Let's go ahead and discuss what we did last week. Last 2 weeks. Last week we covered palpitations, syncope, orthostatic hypotension, and hypertension emergencies. We also discussed atherosclerosis, coronary artery disease, angina, and heart failure. Week prior, our first week, we discussed the cardiovascular exam, echocardiography, and also stress testing, cardiac catheterization, chest pain, and edema, and also pitting edema. Remember that Play-Doh looking syndrome. This week we're going to cover arrhythmias, atrioventricular block, first to the third degree. Between arrhythmias, I think we're going to watch a 10-minute video. That way we can get a good understanding of how they diagnose certain diseases, but mainly a basic understanding of how the ECG works and what we're actually looking at. Then we're going to discuss atrial fibrillation, cardiac valve disorders, acute coronary syndromes, which is your myocardial infarction, and also infective endocarditis, abdominal aortic aneurysm, and deep venous thrombosis. And then we'll discuss varicose veins lastly. Okay, let's go ahead and get this 10-minute video ready for you guys. I'll just go ahead and pull it up on the screen in a second. But understand this is like a short 10-minute video, but it really is a baseline of what these PQRST waves mean, and also it gives you an idea how to diagnose in the future. Pay attention to the 5 rules. You'll probably have these rules on your quiz.
Welcome to the Yellow Belt section of the ECG Mastery Program. We're really happy to have you in our course. We created this belt system for you for 2 reasons. One is we really like martial arts, and the other one is it's easy to understand. Most people know that the yellow belt is the first belt that you can acquire in most martial arts like karate or judo. The owner of the yellow belt knows the basic principles of the sport, the names of the moves, and so forth. Similarly, once you finish the yellow belt section in this course, you'll know the basic principles of the ECG, you'll be able to diagnose very important and potentially dangerous diseases, and you'll understand your colleagues and reports that talk about an actual ECG. And that enables you to further improve your ECG skills on the job. It's very hard to learn from someone if you don't speak their language, right? So in this yellow belt section, we'll teach you the ECG language so you'll be fluent real quick. But let's not waste any time and dive right into the heart of the matter. May I introduce to you the ECG curve. It consists of several distinct waves. Let's look at these waves in more detail.
Let me give you a short intro into the components of the ECG. Let's start off with the QRS complex. The QRS complex represents ventricular depolarization. These QRS complexes are easy to recognize. They're very sharp and pointy spikes. After each ventricular depolarization, there must also be a period of repolarization. and that repolarization is called T wave. The T wave can be positive or negative. Depolarization of the atria, on the other hand, is characterized by a relatively steep wave, called the P wave. Its steepness is somewhere between that of the QRS complex and the T wave. So this is the QRS complex, and it's the steepest part of the ECG. This is the T wave, and it's the least steep part, and the P wave is somewhere in between. We usually can't see atrial repolarization, mainly because it's usually hidden within the QRS complex.
Let's have a closer look at the QRS complex, which, as you know, corresponds to ventricular depolarization.
Each component of the QRS complex has its name. Naming of these components follows a standard nomenclature. There are only 5 basic concepts that you have to understand when it comes to naming these components.
Concept number 1, the first downward deflection is called a Q wave. Concept number 2, any upward deflection is called an R wave. Concept number 3, any downward deflection that comes after an R wave is called S wave. Concept number 4, a second upward deflection is called R prime. And what about this wave here? Is this a Q? Is this an S? Well, to tell you the truth, people came up with a compromise here. They said that whenever there is one large downward deflection, then that's called a QS pattern. So concept number 5 says, if the entire QRS complex consists of one large downward deflection, then this is called a QS wave.
That's it. Now let's look at a couple of examples.
Example number 1. Here we have a rather classical case. According to concept number 1, the first downward deflection is called a Q wave. According to concept number 2, any upward deflection is called an R wave. And concept number 3 says, any downward deflection that comes after an R wave is called S wave. So we have a QRS pattern here. Now let's check out example number 2. As you can see, we have no initial downward deflection in this case. So, according to concept number 2, any upward deflection is called an R wave. So no Q wave here. And according to concept number 3, any downward deflection that comes after an R wave is called an S wave. So we have an RS pattern here. Now let's turn to example number 3. What I'd like you to do here is pause the video and try it out for yourself. Then come back and see how you did. Okay, so now let's see how you did. According to concept number 2, any upward deflection is called an R wave. According to concept number 3, any downward deflection that comes after an R wave is called S wave. And according to concept number 4, a second upward deflection is called R prime. So we have an RSR pattern or RSR prime pattern here. Did you get it right? Okay, so let's try another one. Again, pause the video and try for yourself. Then come back and see how you performed. Okay, so let's see the solution. According to concept number 1, the first downward deflection is called a Q wave. According to concept number 2, any upward deflection is called an R wave. So we have a QR pattern here. Are you ready for some more examples? Well, here we go. Example number 5. Again, pause the video and try for yourself. That was simple, wasn't it? There's only one concept that you have to use here, and that's concept number 2. Any upward deflection is called an R wave. But let me tell you one thing. This type of R wave is actually quite rare. Usually we would see a Q wave here or an S wave here, so you will only rarely see this type of R pattern. And one final example, example number 6. pause the video and try for yourself. Also quite easy. Only one concept fits here, and that's concept number 5. If the entire QRS complex consists of one large downward deflection, then this is called a QS pattern.
Here are the different examples again. Take a close look at them. Example number 1, we had a Q wave, an R wave, an S wave. Example number 2, an R wave and an S wave. Example number 3, R, S, R prime. Example number 4, a Q wave and an R wave. In example number 5, just one big upward deflection, that has to be an R wave. And in example number 6, just one big downward deflection, which of course has to be a QS pattern.
It's time for another little exercise. Now it's your turn to identify the different components of the ECG. Try to identify the QRS complexes and the T waves first, and then the P waves. So pause the video and try for yourself, then come back and see how you did. Okay, so I hope you did the exercise. Let's see how you did. This first part of the curve, very steep and pointy, must be a QRS complex. Then after each QRS complex, there has to be a T wave, so this has to be the T wave. Then this is another steep part, QRS complex. This must be a T wave, rather flat. QRS complex, T wave, QRS complex, T wave, QRS complex, and another T wave. So what we're left with are a couple of unidentified dotted lines and ECG curves. And those curves must be the P waves because the QRS complexes and the T waves we've already identified. So this must be a P wave. This must be a P wave. Another unidentified line must be a P wave. And then another P wave here and another P wave here. What's striking here, though, is that the P2P interval here seems fairly long, and those 3 P2P intervals seem much shorter, right? So these 3 seem to be constant, and then there seems to be a big pause. And one important thing to note is that the P's are only very, very rarely skipped. So we assume that the P wave must be hidden somewhere in this interval. But where? Well, the way to solve this mystery is to take the P2P interval, the regular P2P interval, which would be this. These are 3 regular P2P intervals. And then take this P2P interval and put it right here at the first part of this pause. So we put it here, and so we see that this is the area where we would expect the P, right? So this is where the P is supposed to be. And I can tell you, the P is actually hidden within the QRS complex. That's why those 2 are happening at the same time. And then comes another regular P2P interval. So the mystery for this long pause is solved. But then we have another little mystery. Here, in the period that comes before this P wave, there's no P happening here. So let's take the P2P interval, and we can see that this is the area where we would expect the missing P. And if you look closely down here, you can see that we have a little bit of notching here. That's probably because the P wave is hidden within it.
Now try for yourself. Start the exercises and see how you're doing, and I'll see you in the next session.
Okay, so what did you think? It's actually a pretty good video, pretty good introductory video, definitely a good refresher for anybody that needs a reminder of how those actually work and how they're spread out. It's a really good baseline. So I hope you can take this for your future. And if you want to take it a little bit further, you could actually go into a whole series where you start to look at the pathologies. But I think it's a really good start. Let's go ahead and get finished with the lecture here. All right, so I told you we're going to be covering arrhythmias, so here we go. Arrhythmias. So normal heartbeat is caused by regular and coordinated generation of electrical impulses. And as you know, those electrical impulses trigger organized myocardial contractions. So your normal rhythm is 60 to 100 beats per minute, and it may be slower in athletes and during your sleep. An increase during inspiration and a decrease during expiration are normal, but may lessen with age. Arrhythmias are abnormalities in generation or conduction of electrical impulses. So here is where the nodes take place. Here's your AVN node, right in through here, right? And then you have your right bundle branch down here. This is often, sometimes they can pick up on right bundle branch blockages, and we won't get into it in this lecture because it's a whole series of cardiac lectures that would need to take place in order to understand all of these. And then, understand there's pathologies on the right side of the heart involving the valves, both the mitral, bicuspid, and tricuspid valves, and we'll get into those. Here's your bundle of His right in here, and then you have your left bundle branch, and you have your left posterior fascicle, your LPS. And then you have a lot of connective tissue in there too that could be subjected to trauma, which could show up, and you have some chordal tears in there. And then you have your left anterior fascicle, which is actually down and through here, and your Purkinje fibers down here. So let's go ahead and get into the meat of the lecture. Signs and symptoms. Okay, a lot of times these become, or the patient will be asymptomatic. Sometimes they'll have palpitations, dyspnea, chest discomfort, pre-syncope. They'll also have syncope, and it's diagnosed through an ECG. The treatment, they can actually correct the cause in many cases with drugs and with electrical shock. Also, they'll use antiarrhythmic drugs, pacemaker implantation, cardioversion, ablation of ectopic site of automaticity, and implantable cardioverter defibrillators. So with these atrioventricular blocks, there's either a partial or complete interruption of impulse, and this occurs from the atria, right, to the ventricles. So most commonly caused by idiopathic fibrosis or sclerosis of the conduction system. With a first degree block, you're going to have a conduction that is slowed without skip beats, and this could be normal in well-trained athletes and does not require any treatment and is rarely symptomatic. And this is what the PR interval looks like with a atrioventricular block, first degree. And there's a little time thing right up here. It's at 0.32 seconds PR interval. And that's the difference between the P and the R wave. A second degree block, which is called a Mobitz type 1 or a Mobitz type 2. You'll have, with Mobitz type 1, you're going to have a PR interval progressively lengthens with each beat until atrial impulse is not conducted and the QRS complex is dropped. The conduction resumes with the next beat, and the sequence is repeated. The type 2 PR interval remains constant, and beats are intermittently not conducted, and QRS complex is dropped. With a high-grade block, you'll have every second or more P wave is blocked, and the QRS is dropped. Here's what a AV block looks like with a Mobitz type 2. Okay. Here's another example of Mobitz type 2. And here is a second degree high grade AV block. A third degree block, there's no electrical communication between atria and ventricles, and no relationship between P waves and the QRS complexes. Function is maintained by a ventricular pacemaker or escape rhythm of 40 beats per minute or less, and most of these type patients will require a pacemaker. And also, I mentioned a lot to you guys in the last course about the clean needle technique manual, and there's something in there about contraindications with patients with a pacemaker. Probably a good idea to read over all of those contraindications, and you'll see that test question over and over again. Here's what a third block looks like. And we'll watch a video later on all these disorders so you have a better understanding of what they look like on an ECG. Atrial fibrillation is a rapid, irregular atrial rhythm. And the atria do not fully contract, and the AV conduction system has many electrical stimuli causing irregular ventricular wave. Etiology, most commonly with hypertension, cardiomyopathy, mitral or tricuspid valve disorders, hyperthyroidism, binge alcohol drinking. Signs and symptoms, atrial fibrillation is often asymptomatic. You're going to have palpitations, vague chest discomfort, and pulse irregular. Always say that 5 times fast. Irregular. Pulse deficit. The apical ventricular rate is faster than the rate palpated at the wrists because the ventricular stroke volume is not always sufficient to produce peripheral pressure wave. So pay attention in clinic when you're taking the pulse. There's often people that are considered healthy because they you can hardly feel a pulse in their wrist, and like, oh, it's just I'm a runner. You got to pay attention to that and make sure this isn't the case. So there might be that stroke volume may not be sufficient enough again to produce that peripheral pulse. Diagnosis is through ECG. You're going to have an absence of P waves. The QRS complexes are irregular in timing. And also, whenever you see this disorder, they're going to also, check it out on the echocardiography to assess for structural heart defects, any type of disorder going on in there, any valve disorders. Also, they're going to do a thyroid function test, especially with, hyperthyroidism causes a lot of issues. With increased heart rate and irregular heart rates. Treatment, you want to rate control with drugs. They also do cardioversion and ablation of AV node and insertion of permanent pacemakers. And there's also concern, as always, with prevention of thromboembolism. So you're going to have oral. What we got here? Get that out of here. Oral anticoagulants like warfarin. And let's see, here we go. Yeah, let's go back slightly to this line here with cardioversion. So what is cardioversion? It's essentially it's a medical procedure by which an abnormally fast heart rate, one that's tachycardic or some other cardiac arrhythmia, is converted to a normal rhythm using either electricity or drugs. That's all you need to know about it. So, and I mean, there's a lot. There's whole lectures on cardioversion where they can restore the activity of the electrical conduction, right, system of the heart. Using these electrical currents, and also pharmacologic cardioinversion as well. So, but we don't have time to get into it too much, but just for our baseline, just understand what that means. How do we diagnose atrial fibrillation? Of course, the ECG. There's going to be absence of P waves, and the QRS complex is irregular in timing. The echocardiography we're going to use to assess for structural heart defects, right? Thyroid tests, and all those kind of things. So that's just a review of what we covered so far. Okay, aortic regurgitation is an incompetency of aortic valves causing backflow from the aorta into the left ventricle during diastole. How is it caused? Ineffective endocarditis, dissection of the ascending aorta, rheumatic fever. You have signs and symptoms to include, typically they're going to have asymptomatic for years. They're going to have exertional dyspnea and orthopnea. So what's orthopnea? Orthopnea is you're going to have the same dyspnea, right? But they're lying down, they're at rest. So both at exercise and at rest, lying down, they're going to have difficulty breathing. Palpations, they're going to have a normal S1 pattern or S1 sound. They're going to have non-split with a loud S2 and blowing with a high-pitched diastolic murmur. So just as we have a lot of descriptions for, how it feels, the pulse feels, and how things sound, there's a lot of terminology involved with this. So it's heard best with the diaphragm, with the patient leaning forward, and breath held at expiration. So what do we know about the S1? What do we know about the S1? So whenever you see these S1, S2, S3, and so on, just understand that heart sounds are the noises generated by the beating heart, and you're either going to have turbulent flow or parabolic flow, so it's all going to sound either normal or it's going to sound like it's been somehow restricted. So, and the resultant flow of blood through it, if you have some type of turbulence created when the heart valves snap shut in cardiac auscultation, the examiner may use a stethoscope, right, like yourself, to listen to these unique and distinct sounds. And it provides an important auditory data for you in regard to the condition of the heart. So in sequence, with each heartbeat, begins at S1, right in through here. These are the first heart sound, and second heart sound, S2, is produced by the closing of the AV valves and semilunar valves. So that's what that means. Okay. The crescendo ejection murmur it's heard best with the diaphragm at the right upper sternal border with the patient leaning forward. It decreases with Valsalva and increases with Valsalva release. And diagnosis is through echo. And getting back to this line here, what is a crescendo, decrescendo murmur? Well, it's a mid-systolic ejection, and it's all due to blood flow through the semilunar valves. They occur at the start of blood ejection, which starts after S1 and ends with the cessation of blood flow. So, and it's also diagnosed with the echo. Whenever you have a structural issue, they like to use the echo a lot, right? And the treatment is, if it's bad enough, they go ahead and replace the valve, the aortic valve. talk about mitral valve prolapse. Mitral valve prolapse is a billowing of the mitral valve, and it's a billowing of the mitral valve into the left atrium during systole. Usually it's benign, but the complications can include mitral regurgitation, endocarditis, chordal rupture. Remember we was talking about the the connective tissue and the tendons and all that stuff within the heart, keep everything together. Keep some of the atriums and the ventricles, all that tissue. Sometimes that area can rip. Signs and symptoms: we're going to have mid-systolic click, and it's going to be heard best with the diaphragm over left apex with the patient in the left lateral decubitus position. The diagnosis is with echo and does not usually require any type of treatment. All right. You're going to have mitral regurgitation, which is incompetency of the mitral valve, causing flow from the left ventricle into the left atrium during systole. And this is bad, right? A lot of folks get this surgery with no problem. They get that fixed. But if it's bad enough, they have to actually replace the whole thing. So it's most often caused by mitral valve prolapse, which eventually leads to heart failure as left ventricle compensation fails. They're going to have insidious development of dyspnea, fatigue, orthopnea, palpitations. They're going to have holosystolic murmur. It's going to be heard best at the apex with the patient in the left lateral decubitus position, again decreasing with Valsalva. The diagnosis is with echo, and the treatment is through ECG, or echo, as you were. Then we have mitral regurgitation. So it's incompetency of mitral valve causing flow from the left ventricle into left atrium. All right, so we discussed that already. I'm trying to fix this right here for us. Okay, if you had questions about, this is what I was looking for, the left lateral decubitus position, this is what it looks like. Of course, they're preparing this person for some type of, procedure they're going to do, but the flank is elevated and padded, underneath. So I know some acupuncturists that actually place people in this position, in case, just to treat certain areas, and it actually makes the patient feel more comfortable. Maybe not at that angle, but they use a lot of pillows to actually elevate the flank area. The lower leg is flexed, and the pillow is between the legs. And then there's roll towels to protect the brachial plexus, and safety strap just to keep them on the table, prevent them from falling off the table. But that's what the lateral decubitus position looks like. Also, other cardiac valve disorders include mitral stenosis. So it's the narrowing of the mitral orifice that impedes blood flow from the left atrium to the left ventricle, most often caused by rheumatic fever. So that's pretty serious, right? rheumatic fever causes, other things, other disorders within the organs as well. Complications are pulmonary hypertension, atrial fibrillation, thromboembolism, and symptoms and signs are those of heart failure. These patients will have exertional dyspnea and orthopnea and fatigue. There's going to be a loud S1 heard best at the apex. Early diagnostic opening snap, early diastolic, so that'd be early diastolic. Opening snap as leaflets billow into the left ventricle, followed by a low-pitched decrescendo, crescendo rumbling, diastolic murmur heard in the left lateral decubitus position. And this increases after Valsalva or squatting. The diagnostic for this mitral stenosis is by echo, and the early treatment with diuretics and anticoagulants. Later, the commissurotomy or valve replacement. Acute coronary syndrome, myocardial infarction. This usually occurs when acute thrombus forms in a atherosclerotic coronary artery and blood flow to parts of the myocardium is disrupted, resulting in tissue necrosis. Most commonly affects the left ventricle and reducing the cardiac output. So ischemic and necrotic cells they're no longer capable of normal electrical activity, resulting in ECG changes. Signs and symptoms depends on the extent and location of obstruction. 2/3 of these patients experience prodromal symptoms days to weeks before the event. They'll have unstable angina, shortness of breath, and fatigue. And they'll hit this point up again about unstable angina versus stable angina. Know the difference? Know the difference between those two, please? Deep substernal visceral pain, described as aching or pressure radiating to the back. And females actually have more atypical type of, just symptoms, and just have strange, referred pain and things like that. So always be on the lookout for that. Deep substernal visceral pain, right? Aching or pressure radiating to the back, jaw, or either arm, shoulders, or all of the above. They're going to have dyspnea, diaphoresis. What's diaphoresis? That's sweating. Nausea and vomiting, and it's not going to be relieved. Their normal nitro that they carry, it's not going to be relieved by it. 20% are silent heart attacks, and they are asymptomatic or causing vague symptoms. And this is more common in diabetes. And here's the women bullet down below. Women are more likely to present with atypical chest discomfort. So other signs and symptoms, they're going to be pale, cool, and clammy, and peripheral or central cyanosis. They're going to have a thready pulse. Heart sounds are distant, muffled, and the S4 sound, which is an extra sound, is almost always present. So let's see what it is. We talked about the fourth heart sound, or we talked about S1, S2. The S4 is actually an extra heart sound that occurs during late diastole and immediately before the two lub-dub heart sounds are heard, the S1, S2. It occurs just after the atrial contraction and immediately before the systolic, the S1, and is caused by the atria contracting forcefully in an effort to overcome an abnormally stiff or hypertrophic ventricle. Some of the risk factors involved with it is recurrent angina at rest or low-level activity. It goes hand in hand with what I mentioned before about, whether the patient is resting or whether the patient is exercising, and on previous lectures. So know that, stable versus unstable. Heart failure, mitral regurgitation, and stress tests result of symptom production, ECG abnormalities, ventricular arrhythmias, hemodynamic instability, diabetes mellitus. Here it comes again, it's a big killer, right? Diabetes comes up a lot. We want to prevent diabetes. It's kind of the killer, right? So it's kind of it kind of starts first, with pre-diabetes, and then it leads to a lot of other stuff like cancers and things like that. So the person had prior CABG, or if the person had some type of, or if he had a PCI, which is a percutaneous coronary intervention, which is a non-surgical procedure used to treat the narrowing of the coronary arteries of the heart found in coronary artery disease. And that process involves combining coronary angioplasty with stenting, which I'll show you a picture of here. And they actually insert like a permanent wire mesh tube, and that is either drug-eluting or composed of bare metal. So, and that stent is actually, the stent is actually a balloon. The delivery is from a balloon, from the angioplasty catheter. It's kind of a trip. So yeah, here's a picture of it. And there's a guided wire, and here's the stent material. So yeah, it's pretty cool to actually see one of these procedures. When they use a lot of different X-ray imaging afterwards to visualize it. All right. So we have the next, how do we diagnose this acute coronary syndrome, this myocardial infarction? Well, the ECG, every 8 hours, they're going to have this on the person once he starts experiencing these symptoms for 1 day. Then they're going to track him or her daily for any changes. The cardiac markers are going to show up. They're serum markers of myocardial cell injury that appear at different times after the injury. So you're going to have the troponin, the creatine kinase, and the myoglobin. And coronary angiography after an abnormal ECG. Yeah, so what some of that angiography looks like. They can pick up on disorders, occlusions, and they actually perform these procedures while doing this, so they could actually watch them to see the effects and how they're actually making it work. Here's some of the cardiac markers we talked earlier on. The different colors represent the different markers. So you have red and peach. I think that's peach color. It's kind of hard slide to read, differentiate. But you have hours from onset on the bottom graph, and then the upper limit of the normal on the left. Acute coronary syndrome, myocardial infarction. The way we treat it with oxygen, anticoagulants, antiplatelet drugs. We're going to use nitroglycerin. Initial bed rest for 24 hours, low salt diet, low fat diet. We're going to treat contributing disorders, anemia, heart failure. Complications. There's electrical dysfunction, right? So there's going to be conduction disturbance and arrhythmias. Mechanical dysfunction, heart failure, myocardial rupture, papillary muscle dysfunction, thrombosis, and pericarditis. Infective endocarditis is infection of the endocardium. It's usually bacterial fungal. And how does it start? Usually involves defective heart valves that allow bacteria and fungus to adhere to the endocardial surface, microorganisms in the bloodstream, cutaneous abscess, infected gums. Wow, infected gums. Look at that. So definitely stay on top of your dental work, get your cleanings. UTI, venous catheter can actually cause it. So that I would consider that iatrogenic causes, and a drug injection site. Signs and symptoms of infective endocarditis are low-grade fever, night sweats, fatigability, malaise, weight loss, regurgitant murmur, and tachycardia. You're going to have hemorrhagic retinal lesions, petechia, painful erythematous subcutaneous nodules on the tips of the digits, and transient ischemic attacks, TIAs, strokes, and toxic encephalopathy. How do we diagnose it? Blood cultures, echo again. These blood cultures are 3 within 24 hours from separate fresh venipuncture sites, and identification of the organism and antimicrobial sensitivity. We're going to treat it with IV antibiotics, valve repair replacement, or prophylaxis before procedures. So that includes your dental. All right. Abdominal aortic aneurysm, pretty serious. It's an increase in diameter to greater than 3 centimeters of abdominal aorta, and it typically begins below the renal arteries, most commonly caused by weakening of arterial wall by atherosclerosis. Your risk factors include smoking, hypertension, increasing age, family history, male sex, and black race. All right. So here are some of the symptoms. Most are asymptomatic. It may be steady, deep, boring visceral pain in the lumbosacral region. You could have pulsatile abdominal mass. Diagnosis includes clinical presentation, ultrasound or CT, and CT angiography shows size and extent. The treatment, monitoring if less than 5 centimeters, and if it's greater than that, surgical repair is needed by replacing the portion with the synthetic graft. DVT, we discussed this, I think, in prior lectures. At least we talked about clotting in blood in deep vein of an extremity, usually a calf or thigh. Greater than 60 years, some of the risk factors involve cancer. Cigarette smoking comes up just about every disorder, that it's risk factor, right? Estrogen receptor modulators, oral contraceptives, heart failure, hypercoagulability disorder, and immobilization. So if someone's immobilized for a great period of time or pressing up against your leg, causing a embolus or a thrombus. Limb trauma, myeloproliferative disease, nephrotic syndrome, obesity, pregnancy, postpartum, and Prius venous thromboembolism. Surgery within the past 3 months. It's sickle cell anemia. All right, here's a picture. This looks like a left leg. So, yeah, that's a left leg for you. So thrombosis normally occur, the DVTs normally occur right down here, right in through here, in these these anterior tibial and posterior tibial and peroneal areas. Pathophysiology with the DVT results from impaired venous return, endothelial injury, or hypercoagulability. Usually begins in venous valve cusps, and the complications include chronic venous insufficiency, stasis ulcers, and pulmonary embolism. Factors in presentation that increase the probability of DVT: tenderness along vein distribution in calf or thigh, unilaterally swelling of the entire leg, and calf swelling greater than 3 centimeters, difference between calves, pitting edema in affected leg. Yeah, that's something I didn't know before. So there's your pitting edema again. Dilated superficial vessels, and veins, and cancer. Immobilization, history of surgery within the past 4 weeks. All right. Diagnosis, ultrasound, D-dimer test. Determination of cause, if not from immobilization. So, what is D-dimer? Right? D-dimer is a fibrin, and it's a small protein present in the blood after a blood clot is degraded. So it's also named because it contains 2 D fragments of that particular fibrin protein. And so, yeah, so this D-dimer concentration may be determined by a blood test to help diagnose thrombosis. And so that's how they know, that's how they diagnose it. How do they treat it? They inject anticoagulation therapy initially, oral anticoagulant for 3 to 6 months. Wow. If risk factors were transient, and lifelong if unmodifiable. Prognosis is 3% risk of fatal pulmonary embolism without treatment. And the prevention is definitely increased mobility, risk assessment prior to invasive procedures, and intermittent pneumatic compression. So, good to know. Varicose veins. These are dilated superficial veins in the lower extremities. May result from primary venous valvular insufficiency with reflux. Signs and symptoms: initially tense and palpable but not visible. Progressive enlargement, protrusion, mostly visible on standing. And diagnosis is by clinical evaluation. They use compression stockings. You can buy them at Walmart or buy them at any drugstore. Sclerotherapy or surgery, but new varicoses will develop after. This is what happens. So those are some awesome shoes. Have to buy a set. Now it looks like this guy's a bicyclist, probably stopping at Starbucks. All right, so this is what we covered this week. It's a week 3 summary. I'll be sending you another series of ECG videos that I would encourage you, they're not mandatory, but I'd encourage you to watch them to get a better understanding of the ECG. What we covered today is arrhythmias. We covered AV blocks, 1st through 3rd. We talked about atrial fibrillation, cardiac valve disorders, acute coronary syndromes, and myocardial infarctions. We talked about infective endocarditis, abdominal aortic aneurysms. Those all sound very serious, and they are. Deep venous thrombosis and varicose veins. So that summarizes everything we covered this week. I hope to see you guys in class, and we'll go ahead and meet. Expect a quiz on week 2s, week 3s. We'll discuss that as far as timing is concerned. I know most of you are done with your exams, but I want to get a good handle on your schedule and try to make it worth it. Try to spread it out a little bit so you guys have a better time studying and more advantageous for you guys. All right, with that in mind, we'll see you soon. Talk to you soon.